So laparoscopy literally means to look inside the abdomen. It allows visualization of the abdominal and pelvic organs. So what is the difference between open versus laparoscopic surgery? I will just submit all in next few slides, and then we'll shift to the surgical aspect of laparoscopy. So what is the difference between open and laparoscopic surgeries? Laparoscopic surgery will have smaller incisions. It will have shorter recovery time as compared to the open surgery. It will also have shorter hospital stay. It has less post-operative pain and discomfort as compared to open surgery. Open surgery means we literally cut open the abdomen, go inside and operate. While in laparoscopy, as I've already mentioned, that we make small keyholes and then we put trocars and then access the surgery. So along with the other advantages, laparoscopy leaves minimal scarring as compared to open surgery. It has lower risk of infection. It has higher precision due to enhanced visuals. Right? In open surgery, we can see what our eye capacity is allowing us to see. In laparoscopy, with the help of magnification, we can see even the minute detailing of the organs. And also, laparoscopic surgery has a potential for fewer complications as compared to the open ones. So now, these were the advantages of laparoscopy over open surgery, but what are the limitations of laparoscopy? So first and foremost, it reliance on the remote vision and operative system. Secondly, loss of tactile feedback. Many of the times we fail to struggle the consistency of the tissue while operating, right? Which we can easily identify in open surgery. You take some time to develop that tactile sensation in case of the laparoscopy. Dependence on hand and eye coordination, right? Right from the childhood, we are blessed with the hand-eye coordination, and that helps in open surgery. But when we are talking about laparoscopic surgery, we are not seeing towards the patient, we are actually seeing towards the screen, and that needs to be developed over a period of time. So the greatest challenge of learning laparoscopy is hand-eye coordination. Difficulty with hemostasis. Now we are having multiple vessel sealers, bipolars, etc. But none of these instruments will match the hemostasis that is achieved by ligation, which we are free to do in open surgery. Reliance on new techniques such as advanced cauterization, etc. And extraction of large specimens is really difficult while performing laparoscopy. So what are relative contraindications of laparoscopy? Compromised cardiac status, peritonitis, previous abdominal surgeries, bleeding disorders, morbidly obese patient, and third trimester pregnancy. These are the relative contraindications of laparoscopy. So now, before moving to the actual surgical part, just I would like to mention the history. World's first laparoscopic appendicectomy was performed by Kurt Sem, which happened to be a gynecologist and not a surgeon. In 1980, he performed laparoscopic appendicectomy for a first time. World's first laparoscopic cholecystectomy was performed by Dr. Eric Mu. He was from Germany and he performed that in 1985. India's first laparoscopic cholecystectomy was performed by Dr. Woodwardia in 1990. So what are different indications of laparoscopy, right? There are multiple indications where we can use the laparoscopic work for diagnosing and even for therapeutic causes. So for infertility, laparoscopy is a boon. We use to check the tubal patency. In cases of endometriosis, it helps us in creating the staging and also to release the pelvic adhesions. In cases of acute pelvic lesions such as acute ectopic, acute appendicitis, acute salpingitis, etc., laparoscopy is of great help. Also, in cases of diagnosing pelvic masses such as fibroids, ovarian cysts, other adnexal cysts or masses, and not only diagnosing, it helps us in treating them as well. In cases of many follow-up of pelvic surgeries such as ovarian malignancy, evaluation of endometriosis, suspected Mullerian abnormalities, and uterine perforations, laparoscopy is has been proven to be a gold standard for diagnosing. So now today I will be focusing more on total laparoscopic hysterectomy and myomectomy. I have not brought complicated videos, they are already there on my YouTube channel. I'm going to describe a standard procedure for total laparoscopic hysterectomy and myomectomy and how to finish them off within a record time, right? So before moving to video part and the standard steps, Harry Reach performed the first laparoscopic hysterectomy in 1989 in Pennsylvania. This is just the history that I thought was relevant. So what are the advantages? There's always a common debate whenever we are discussing about the advantages of laparoscopy. Few people will come and say that, okay, laparoscopy is minimal invasive, but vaginal hysterectomy is absolutely non-invasive. There is not even a single cut on abdomen, but it is a blind procedure, right? Being a gynec, I can understand the pain while performing the vaginal hysterectomy, especially when we are dealing with the larger adnexal masses. In cases of endometriosis, where the adhesions are expected, where the planes are distorted. In cases of prior abdominal surgery, again the reason being adhesions, and also in cases of narrow pubic arch or poor vaginal descent, vaginal hysterectomy is a nightmare as compared to laparoscopy. So it is always better to perform surgery under observation than just making a use of predictive anatomy and doing it vaginally. So from my perspective, from grade 3 or grade 4 prolapse onwards, it is always vaginal hysterectomy to be preferred, but for all other cases, laparoscopy definitely has an edge over vaginal hysterectomy. So what should be the position of the patient, right? So the ideal position of the patient should be Trendelenburg work, which is nothing but head low at an angle of 16 degrees with the foot position. Arms should be tucked in. The patient's legs are flexed at hip and knee joints and are placed in stirrups using caution to prevent comparison on the lateral calf and thus to prevent the peroneal nerve damage. This is also very important when you are posting a patient for larger hysterectomies or longer duration surgical procedures. So before moving on to the actual surgery video or discussion, there are only a few points about the anatomy that one needs to understand while performing hysterectomy or any uterine surgery for that matter. Two things are very important. First one is ureter and the other one is the uterine artery. These are the two things that one needs to understand their course and also whenever they are expected to perform the total laparoscopic hysterectomy. So the uterine artery arises from the anterior division of the internal iliac artery. It crosses the ureter anteriorly, reaching the uterus by traveling in the cardinal ligament. Cardinal ligament is nothing but transverse cervical ligament. It travels through the parametrium of the inferior broad ligament of the uterus. Along with the uterine artery, ureter also is very important. So we commonly know that at the level of S1 or at the level of sacral promontory, ureter crosses from lateral to the medial side exactly at the bifurcation of the common iliac artery. So ureter enters into the pelvis at the bifurcation of the common iliac artery in front of the sacroiliac joint. In females, the ureter passes above the lateral fornix of the vagina, lateral to the supravaginal portion of the cervix, and lies below the broad ligament and uterine vessels. So always remember, ureter is going to be there approximately 1.5 centimeter lateral to the cervix, and you need to assess not only the cutting of your instrument but also the lateral spread of your instrument. Whichever instrument you are using, you must have the position of ureter in your head. So creating pneumoperitoneum, this is first and most important part of any laparoscopic surgery for that matter. So at my setup or where I got training from, we put varies always at the Palmar's point, be it the normal surgery or previous adhesions or whatever it is, because out of the entire abdomen, it is the most safe point. It is the safest point entry that is on the abdomen, and as a routine, generally in books or in guidelines, as per the guidelines, you should use Palmar's point in cases where there are multiple past history of surgeries or adhesions are expected. But as a routine, we follow the insertion of Veress needle at the Palmar's point, or even at times where I will show you the pictures also, wherever there is a vertical incision, supraumbilical incision, we even put a primary 10 mm trocar at the Palmar's point. So, what is the Palmar's point? So, Palmar MD was a French gynecologist. Palmar's point is described as the area in the left upper quadrant 3 cm below the costal margin and in the mid-clavicular line. This entry is utilized when midline adhesions are suspected, but as a routine at our setup, I am following this point of entry. So now I will show you the video of how I actually prefer creating a pneumoperitoneum.
In Palmar's point approach. So what is Palmar's point? Palmar's point is a point which lies around 3 cm below the left costal margin in a mid-clavicular line.
Just a point to make that never lift the abdomen while putting your first entry point or a Veress point. That is the common mistake every laparoscopic surgeon tends to do. Whenever you lift the abdomen, vacuum pulls, because it is a closed cavity. You are lifting the abdominal layers, it is going to push the bowel and momentum along with it due to the vacuum pressure. You can easily put it without lifting the abdomen, right? No need to put
using
the abdomen.
I took a small incision.
Even if your, let us suppose you have not deflated the stomach enough, you have not inserted the RT, you are going to damage the stomach with the Veress needle. Nothing is going to happen to the patient, right? So just put the patient for NBM for let's say 20 to 24 hours, patient is going to be fine. Veress injury is not significant whenever it is related to the stomach, and the only structure that will be damaged by Palmar's entry point is nothing but the stomach.
At Palmar's point, and then now I am inserting the Veress needle. Remember, Veress needle is to be inserted at 90-degree angle with the skin without lifting the anterior abdominal wall. You generally get 3 clicks, and after 3rd click you are definitely inside the abdominal cavity. You should confirm Veress position by performing aspiration, injection and saline drop test before you connect CO2 cable. Another way of confirming your entry into the abdominal cavity is that you are starting intra-abdominal pressure, which is shown on the monitor or CO2 insufflator, should be less than 10. Around 1 to 1.5 liter of gas is to be passed inside the abdominal cavity.
So here the mass was huge. I wanted to have a superior view of the camera, and I also wanted to preserve a great space for maneuvering the uterus. I prefer to put the primary trocar 4 cm above of the umbilicus, but it is up to you. Few surgeons prefer inserting it inside the umbilicus for cosmetic results as well. It is up to you. Wherever you feel comfortable, you can put the primary trocar.
As this patient had huge fibroid on sonography, I have decided to put primary port.
Now this is blind trocar entry. Now the surgeons will always say that open technique will always be better, Hassan's technique will always be better. I don't want to go into that debate, right? I have performed more than 5,000 cases by now. I have not injured any organ as of now, and also it is always about the time against the outcome, right? So I don't want to spend like half an hour to create a pneumoperitoneum. I want to finish my case within half an hour. So I as a gynec, I feel most comfortable with this technique.
Around 4 finger breadths above the umbilicus. After taking incision of about 1 centimeter using stout knife, I have inserted 10 mm primary blunt trocar by using rotatory movements. Immediately after the insertion of primary port, you should insert camera inside and confirm your intra-abdominal position of primary port. Also, you should always examine the entry sites to
Now these are going to be the common port entry points for all the pelvic surgery, be it laparoscopic hysterectomy, be it laparoscopic ovarian cystectomy or myomectomy, whichever you do. I'm only talking about the gynec pelvic surgeries, nothing else. So I generally put 3 secondary trocars followed by the primary 10 mm entry trocar. But as this was a huge mass, here I will demonstrate insertion of 4 secondary trocars.
have the injury caused by the primary trocar. Let's insert the secondary ports now. So the basic principle of putting secondary ports is that the nearby secondary ports should be at least 4 finger breadths apart to avoid the intra-abdominal blocking of instruments. Also, you can use the trans-illumination test to avoid damaging the anterior abdominal wall vessels. So as you can see on the screen, all the secondary ports are to be inserted under observation. Advantage of inserting secondary ports under observation is that
Apart from the primary port, all other ports in this particular case are inserted under observation. It has not been recorded, but I am mentioning it again that every other port is inserted under observation, right? I have learned from Dr. Kuntambekar where we used to put the first trocar also under observation. It is available as a VisiPort which has a camera inside, and you go dissecting through the every abdominal layer, and that you can see actually on the screen, right? So even if your patient is cost effective, even your first trocar can go inside under observation. But here first trocar entry was blind, followed by
there are less likely chances of injuring internal vital organs. Position of primary as well as secondary ports varies from surgeon to surgeon. So let's put the secondary port. As you can see on the screen, it should always be under observation, and always remember you should go at 90 degree till you engage the peritoneum, and as soon as you engage the peritoneum you should change the direction.
This is an unedited video, except that I have put the 2 ports from this side. I have traveled to the other side to put the second ports, right? You can count the time.
Towards your target organ. Avoid taking smaller or bigger skin incision for port entry. Adequate port incision makes your job easy, and as you can see on the screen, I have engaged the peritoneum, and after that my direction was pointing towards the uterus, which is my target organ. So one more important thing, how to avoid injuring inferior epigastric artery. So inferior epigastric artery lies on an imaginary line which joins umbilicus to the midpoint of anterior superior iliac spine and pubic symphysis. Avoid your port entry on that imaginary line to avoid injuring inferior epigastric artery. So as you can see on the screen, I am done with my pneumoperitoneum. For normal or simple surgery,
So these are going to be my standard ports. This will be the primary trocar or the camera port. 2 ports on the left and 2 ports on the right. I am one of the surgeons who operates from the right. So I first put varus from the left, then followed by 2 secondary ports. Then I will travel to the other side and put these are assisting ports for me, and those are the operating ports.
I use one primary 10 mm port along with 2 or 3 secondary ports. As this was a difficult case, I have used 4 secondary ports here, and by following simple tech.
So let's go back to our PPT. So these were the port placements, right? So here you can see the previous vertical scar. So to avoid all the complications associated with the supraumbilical entry or umbilical entry, I have inserted the primary port at the palmar point itself, right? And that was the post-operative picture of the port placement. So now, today I am going to describe a very simple case of hysterectomy, right? No show off, but I am telling you, if you take more than 20 minutes time to perform a simple laparoscopic hysterectomy, then you are doing something wrong. How we can perform, I will just elaborate. So what are different steps of total laparoscopic hysterectomy? First, after you enter the abdomen, complete survey of the abdomen is to be done to rule out any visceral injuries at the time of entry inside of an abdomen. Secondly, insertion of a myoma screw. So I do not use vaginal manipulator or vaginal tube to manipulate. I use myoma screw. At RH Women's Hospital, we don't use vaginal manipulator for uterine manipulation. We routinely use the myoma screw for uterine manipulation during total laparoscopic hysterectomy. Others, we must have seen, might use uterine manipulators which are to be inserted vaginally. Uterine hitch technique is also there. Uterine elevators are also of great help. You can use as per your convenience. Remember, myoma screw is to be avoided in two of the situations: in endometrial cancer, where peritoneal spread of the tumor cells is feared, and also in patients with pyometra in cervical cancer, where insertion of the screw would lead to spillage of pus inside the abdominal cavity. So wherever you don't want an intrauterine pathology to get spread or to get spilled inside the peritoneum, definitely you would want to skip the insertion of myoma screw. These are the only two contraindications that I could think of to avoid the myoma screw. So now, after putting camera, now you have inserted the myoma. Now, what are the key steps of performing total laparoscopic hysterectomy? So next step will be to deal with the cornual structures, right? What are cornual structures? Fallopian tube is there, round ligament is there, ovarian ligament is there. So we always believe in starting from the round ligament, followed by dissection of the fallopian tubes and ovarian ligament in that order. I'm going to describe all the major steps first, and then I will show you an unedited video how easily you can perform the hysterectomy. After, let us say, dissecting the cornual ligaments, next step will be dissection of the broad ligament leaves, right? So the broad ligament has two layers, right? So we will divide or dissect the anterior leaf, also called as A cut, which extends from the ipsilateral round ligament to the contralateral round ligament. P cut or posterior cut extends from the ipsilateral round ligament to the apex of ipsilateral uterosacral ligament. A cut is also synonymous with bladder dissection or bladder mobilization. What is the importance of these A cuts and P cuts? That you are marking your territory. You are at no point of time in future till you finish off your hysterectomy, you are supposed to go beyond these markings, right? So now you have not yet started your dissection. The uterine anatomy is intact. You have marked the markings that the P cut is going to extend from this point to this, anterior cut is going to extend from this point to this. After you start dissecting uterus, the anatomy is going to be distorted, but these are the markings that will guide you that to avoid the lateral dissection or to injure the ureter or other visceral organs. So immediately after the round ligament is incised, the uterus is pulled keyfold to recreate the traction, counter traction concept of open surgical dissection of the lower uterine segment. This elevates the uterine arteries along with the lower cervix away from the ureters, right? So using the myoma, now you will give traction, counter traction, so that your plane of dissection goes away from the ureters and it prevents the ureteric injuries. So now there are only two key steps in performing TLH. First one is bladder dissection, the other one is uterine artery coagulation. Uterine artery is the chief supply of your organ that you are dissecting, and and bladder is adherent to the lower uterine surface. So how to dissect bladder? There are only two principles of bladder dissection. First, that you stay anterior to the bilateral uterine arteries. At no point of time you are supposed to cross these markings. And secondly, whatever fat that is that you are going to see while dissecting should go along with the bladder. Fat belongs to the bladder. That is the key. Now after you have dissected the bladder also, next step will be to coagulate and cut the uterine artery. As a routine, we advise using bipolar forceps for coagulating, right? No matter whether you are using harmonic, ligature, or sonicision, always the standard instrument to coagulate the uterine arteries will be bipolar forceps, right? So 3-point bipolar technique is to be used where we coagulate uterine artery using bipolar forceps at 3 different points, and then we cut in the center with the scissor or whichever instrument that you are having, right? So bipolar forceps is the preferred instrument for coagulation of uterine artery. So now I have dissected down the bladder. I have now lateralized the uterine artery. Now the next step is to open the vault, right? Opening the vault means you are now physically separating the uterus from the vagina. So we always open vault at the apex of uterosacral ligament and then extend it circumferentially. Most of the surgeons also insert vaginal tubes or vaginal manipulators and then dissect it laterally to open the vault. So these are various steps, but how to save time? See, you cannot take 4 hours, 5 hours of time to perform simple TLH, right? So how to save time while performing laparoscopic hysterectomies? Where we can save our time. Use of myoma screw gives appropriate manipulation compared with vaginal manipulator. Also, tip here is to avoid changing of myoma position frequently, right? I have seen so many surgeons, they will put myoma anteriorly, then they will shift to posterior, then they will go to lateral. Do not change the myoma position frequently unless it is a huge uterus. You can simply put it exactly at the center of the fundus and then proceed with your surgery. Finish off the ipsilateral. Now this is again a debatable point. I do it this way. You can devise your own method, right? I perform bladder dissection, ipsilateral coronal structures, ipsilateral uterine artery, then I open the vault. I finished almost 70% of the vault, but still I have not touched the contralateral coronal structures. I have not yet touched the contralateral uterine artery. Now that is debatable, right? This works for me. You decide what works for you. So make a habit of being ambidextrous while operating, right? Ambidextrous means make a good use of both of your hands. You should be able to operate from both of your hands. It will save some time for you. And lastly, make appropriate use of bipolar forceps to coagulate larger vessels and pedicles. Now again, I just demonstrate a video. This was performed like 2 days back. I have not edited it properly. I just brought it. It's an unedited video. I will just play it on 2x to save some of our time. So let's start. As a rule, we are starting with the coronal structures. Here I am using bipolar forceps in my left hand and a shear in my right hand, right? As a rule, I prefer starting from the round ligament. See, the round ligament goes away, followed by dissection of ovarian ligament and the fallopian tube. This was not recorded by means of finishing the surgery like in a record time. This was a routine case This is posterior cut that we talked about, that we are marking our margins, that beyond this I am not going to dissect at any point of time. Posterior cut will be followed by anterior cut. Anterior cut is nothing but bladder mobilization. This is on 2x, right? This is on 2x. The entire of the fat that you can see, just push it away along with the bladder. And the second point was to stay anterior to the bilateral uterine arteries. Now, I have asked my assistant to grasp the bladder so that it gives me some counter traction for dissection. She was previous 1 LACs. If you can notice, there are central adhesive bands as well. This was previous 1 LACs. Do not panic by small oozers and just ignore them. They will stop on their own. I see so much of panic in the operation theaters with even small oozers, right? You're not supposed to get panicked. They will stop on their own. Do not coagulate each and every oozer. After bladder that was the bladder mobilization. After bladder mobilization, the next crucial step will be the uterine arteries. So again, as a rule, we advocate usage of bipolar forceps. Now, immediately after lateralization of the uterine artery, now my next step is to perform the colpotomy. I have not touched the contralateral corneal structures yet. The contralateral uterine artery is still intact, right? And still, surprisingly, it is not bleeding much, right? This is nothing but specimen site bleeding. Now I will just perform the colpotomy here at the apex of uterosacral ligament that I have already described. Why? Because at the base of uterosacral ligament there will be ureter which will be passing. Colpotomy means you have to separate the vagina from the uterine attachment. There it is. Colpotomy has happened. Now I will just extend it circumferentially. This much of bleeding is okay. Do not get baffled by the specimen site bleeding. Some amount of bleeding I feel is good, right? Excessive charring also disturbs the wound healing post-operatively. Almost 70% of the colpotomy and almost 90% of the hysterectomy is finished, and still contralateral uterine artery is intact. I have not touched round ligament, fallopian tube, ovarian ligament, and forget about corneal structures. I have not touched the contralateral uterine artery as well. Right? Almost 70% of the colpotomy has been done. Now I will move the myoma screw and then start performing hysterectomy on the contralateral side. Why so? Because I have been trained like this, right? If you feel comfortable dissecting one corneal structure after the other, one uterine artery after the other, you do it your way. This works for me. Find out what works for you. See, for me, there are only two principles of surgery. First one is to conserve the anatomy. Do not play around with the anatomy. and the other one is hemostasis. That is the contralateral uterine artery that I am coagulating right now. This is the remaining colpotomy that I am doing from this side, right? That's it. That was it. What was the time? It was 14 minutes and 43 seconds, right? If you follow common steps, if you follow anatomy, you are not going to require more than 20 minutes, trust me, right? So if you are doing like 4 hours of hysterectomy, 5 hours of hysterectomy, something is lacking, go get trained yourself from a good surgeon. So now the next case will be laparoscopic myomectomy. So it was first described at 1979 by SEM exclusively for subserous myomas. From the beginning of 1990s, the technique was developed to include extraction of intramural myoma. So how to proceed ahead for a myomectomy, right? How we can prepare preoperatively for the patient is correction of anemia, because in myomectomy the blood loss is expected, right? So you need to prepare your patient preoperatively by maybe blood transfusion or by correcting the anemia by whichever mode is possible. GnRH analogs can be used in cases of large size fibroids to reduce the size, but their role is controversial. What are the indications of lap myomectomy? Any symptomatic fibroid of any size is to be removed. Size should be less than 10 centimeter, right? Number should be less than 3. This is a relative indication, right? We commonly see patients having 5, 6, 7 fibroids, and then we perform them laparoscopically. It depends on surgical expertise. So that is a relative contraindication. So what are now surgical steps of laparoscopic myomectomy? Before moving to the myomectomy, the most important step is how you are going to reduce the intraoperative blood loss, right? So first, I have already described GnRH analogs pre-treatment to reduce the size. Smaller the fibroid, lesser is going to be the chances of complications or the hemorrhage. Injecting diluted vasopressin, that I don't follow in my setup, right? I do not believe in injecting vasopressin because why? Because first of all, it is a relative contraindication for all these kind of cases such as congestive heart failure, bronchial asthma, PI syndrome, migraine, epilepsy, etc. And also it causes discolorization, and some amount of natural color of the tissue helps you diagnose the fibroid from its capsule, right? So I believe in aqua dissection. I only use normal saline to perform the aqua dissection, right? And it has given me better results than even vasopressin, because the action of vasopressin is going to last only for 15 to 20 minutes. It is not going to give you like 1 hour of blanching or 2 hours of reduced hemorrhage. It is only going to be there for 15 to 20 minutes, and it comes with all these contraindications as well. The other one that recently is making so much of hype is uterine artery coagulation or ligation at origin, right? So again, this is a very controversial point. Many of the standard books also have recently started mentioning this technique. But again, why it is controversial? Because in cases majority of the cases of lap myomectomies are being done for infertility treatments, right? You cannot ligate chief arterial supply of your organ and expect the female to conceive, right? It is like blocking your coronaries and expecting your heart to work normally. So this is again a controversial. Now to replace this coagulation, they have brought out the ligation part, right? But even ligation, you need to release every 20 minutes and retie it to prevent the oxidative stress damage caused to the brain and other vital organs, right? So that is physically not possible to ligate uterine artery at origin every 15-20 minutes when we are talking about cases of 2 hours or 3 hours long. So just forget about it. So how to take an incision before moving or enucleating the laparoscopic myomectomy? So both longitudinal and transverse incisions can be used. Our method of choice is the longitudinal incision, as I perform suturing by ipsilateral ports. Ipsilateral means from one side itself. I prefer suturing from the one side, so longitudinal incision is to be preferred. This makes it easier to manipulate the needle driver than with the transverse incision, right? So if we use a contralateral port configuration, the transverse incision is the preferred technique, as suturing can be performed easily. Contralateral means one hand will be from the one side of the camera port, the other will be from the other side of the camera port, which makes it a lot easier, but then it is cumbersome for your assistant and is not recommended commonly. But from ipsilateral point of view, longitudinal is very much helpful. Next step will be enucleation, right? So first we grasp the fibroid with tooth forceps and pull the fibroid while the assistant places counter traction on the myometrium. To dissect the fibroid smoothly, traction of the myometrium by the assistant is extremely important, right? While enucleating the fibroid, counter traction is to be given by your assistant. During the enucleation, if we encounter hard fibrous tissue, we would cut the tissue with a monopolar knife or scissors and then continue with blunt dissection. This combination of sharp and blunt dissection is repeated until the fibroid can be removed, right? So there's always a combination of blunt and sharp dissection. The next step will be suturing or reconstruction. How to suture the myoma bed that is now left open? We can use two suturing techniques: simple intermittent sutures, and the other one is baseball suturing. Baseball suturing is only meant for the serosal layer of the myoma, right? It is not going to give you strength. The simple intermittent sutures are to be taken where you are having a deep myoma enucleated. Baseball sutures can be used for subserosal fibroids where only the serosa needs to be taken care of. But why baseball suturing is important? Because it prevents post-operative adhesions, right? It is not exposing any of the raw tissue to the peritoneum, right? So now just I'll show you a video of myoma, and then we'll just finish it off. Last 2-3 slides are left.
As you can see here, a fibroid of 4 by 4 centimeter size was.
This is an edited video. This is not an unedited video, right?
Seen arising from the fundo anterior part of uterus. So let's start with our procedure. So as I have already described.
So I have not used vasopressing. I have only used normal saline. I prefer injecting 200 to 300 ml of normal saline into the fibroid. It has given me comparable blanching as to that of vasopressin. It doesn't have any contraindications and it is equally effective. So after injecting and achieving a good amount of blanching, we can just dissect off the fibroid capsule.
In many of my previous myomectomy procedure videos that I refrain using vasopressin and I perform ECMA dissection using the normal saline itself. So approximately 200 to 300 cc of normal saline was injected by using the irrigation needle, and following which, as you have seen using the laparoscopic shearer, I have dissected the fibroid from its capsule. So as you can see, I have asked my assistant to insert a myoma screw in the myoma, which is helping me maneuver the myoma and give the counter traction for its separation from the uterus. So always remember, myoma is to be dissected off by using a good combination of traction and counter traction using any of the devices such as harmonic, ligature, the cold knife, or as you can see in this video, I am using the laparoscopic shearer. So as you can see, within a matter of few minutes, I have dissected entire of the fibroid and there has not been even a drop of bleeding. So if you perform a good aqua dissection and if you remain within the right,
I have only selected smaller sized fibroid, smaller sized uterine specimens because I wanted to focus more on the methodology. I could have brought like 20 weeks fibroid or a bulky uterus. That is not going to help us learn the basic technique, right?
then there won't be any excessive bleeding. So as you all know, myomectomy is not only about the separation or dissection of fibroid, but it is also about uterine reconstruction. So let's start with our uterine reconstruction. Here I am using barb suture for making my job easier, but I have already uploaded so many of other videos where I have showed how to reconstruct the uterus using the Whitefield 10 suture. So here I am going to demonstrate the baseball suturing, which is commonly used for uterine reconstruction. This is the easiest way.
I will just put it on 2x, the suturing part. See, this is a special type of suture called as barb suture, right? It has serrations on the bilateral sides. It is helpful especially for performing the uterine reconstructions because it has the capacity to grasp the tissues, right? It is not going to slip away. You can also perform it using Vicryl, but it is going to be a tedious job as compared to the barb sutures. I'm sure Medtronics will also put a display of their barb suture maybe. So that's it. In a matter of few minutes, you can close it. You don't need any assistance for suturing if you are using a barb suture. So a good quality barb suture is definitely going to reduce your headache. And now how to get rid of the specimen. So this is a morcellator, an Indian made morcellator, works fine. Now last two slides are from the Medtronics. Now this particular system has been launched like few years back and I have worked myself with this and it is a very brilliant instrument. Now where to use it? This is an advanced hysteroscopic resectoscope. Now we must have seen removing polyps or septums using the electrical energy generated or cautery based resectoscopes, right? This is nothing but mechanical resectoscope, you can say, right? So true clear hysteroscopic tissue removal system works on the mechanical principle. It will go inside the abdomen and it has a grasper and it will just mechanically morcellate the intra-abdominal septums or say polyps or even submucous myomas. I have personally used it, but because of the cost, I presently do not have this at my setup, but definitely a wonderful instrument to recommend. So the TrueClear, the cost is 25 lakhs, by the way, right? So the TrueClear system offers a complete technology platform for the removal of a range of intrauterine abnormalities such as fibroids, septums, or even RPOCs. At Pune, I have seen so many of retained products of conceptions being removed using TrueClear system. Hysteroscopic tissue removal system uses a simple mechanical approach to remove intrauterine tissue. Now, what is its main advantage? See, we are talking about intrauterine cavity here, right? We are not talking about peritoneal cavity. We are talking about intrauterine cavity. We are dealing with endometrial specimens such as polyps, fibroids, etc. Whenever we are using electrical energy inside of the uterine cavity, there are going to be chances of post-operative Asherman syndrome or post-operative adhesions, right? So this entirely bypasses those intrauterine adhesions. Secondly, there won't be any chances of bubbles or electrical energy in the uterus, reduces the risk of air or gas emboli and the risk of patient harm. So no documented air embolism or gas embolism with the use of TrueClear hysteroscopic mechanical morcellation system. The other one, last instrument I'm going to describe and I'm going to stop here, is sonicision, right? So it is comparable to the harmonic from Johnson & Johnson. Wonderful instrument. Why? Because it has a generator made or installed inside its handpiece itself. You don't have to carry entire box of generator along with you. You can just carry the handpiece and you can start operating wherever you go. What are its advantages? It is a portable cordless ultrasonic dissection device, right? It is an ultrasonic or USG based device, dissection device. It is cordless, and this design improves freedom of movement and makes it easier to pass the device within surgical procedures. Integrated torque wrench provides the potential for increased setup efficiency by reducing the number of steps and items needed for assembly. Reusable battery. It has a reusable battery, non-sterile battery with an overall useful life of 200 procedures. Intuitive dual mode activation button allows transition between minimum and maximum energy modalities without taking your eyes off the surgical field. It will give you a signal or a beep and it will then shift to the maximum mode. Battery charger is easy to interpret and battery end of life indications enabling efficient battery usage management. So again, this is again a wonderful incision, wonderful instrument, especially being used for finer dissections such as retroperitoneal dissections, dissecting the ureters, repairing the fistulas or performing laparoscopic hysterectomies, etc. This is a very good instrument. Thank you everyone for your patient listening, and thank you Medtronics as well for allowing me to speak on your behalf. I hope I have not bored you all, and let us now hear to the next speaker. Thank you.